the EMDR News segment. All right, I think we're good. I don't know if my sound was on there, so I apologize if that was the case. But again, good morning, everyone. Tim Vermillion, EMDR News. I come here at 9:30 trying to make sure that I get out the information, brief updates, emerging research, and commentary on EMDR, trauma treatment, mental health, veterans care, and stories shaping clinical practice. The idea is to do signal over noise, okay? So I'm just gonna do a quick little discussion on what's been going on. So we have the PBD, the Borderline Personality Disorder Study. There's a feasibility study that was pretty cool. And again, it's just a feasibility study. So when we have feasibility studies, we look at the generalizability of the study itself. Does this tell us anything that we can really bring to our own clients, or that we can say definitively that this helps more than, more than it doesn't help? So we want to look at the feasibility studies as studies that are kind of saying, hey, should we study this a little bit deeper, right? And so we did find a borderline personality disorder study that was doing exactly that. What they would do is they would have a group of people that were going through treatment for borderline personality disorder, a DBT program, a dialectical behavioral therapy program. And as they got to the halfway point, a couple months in, they would switch and have half of the people do EMDR and half of the people continue with just the skill building. And what was found in the feasibility study is that there was an effect, that people did find better results when they were combining those two things, when they had the EMDR afterwards. And there were some of the participants that actually noted that the ability to do the trauma work was helped by the ability to have those skills from the DBT program. There was also something along the lines of dissociation, where they found that people had less dissociation after doing the EMDR piece. There's also been a study out there, which is pretty cool, in my opinion, kind of looking at the depression and anxiety piece, right? So they looked at 40 or so studies that had demonstrated people were actually benefiting from EMDR on something other than post-traumatic stress, because right now that's where most of the information is from post-traumatic stress. So when we find that it's not just post-traumatic stress, but also depression and anxiety, we can start to say more about who we can treat and whether we could possibly put it into practice guidelines for the WHO, the other organizations with other countries that deal with mental health, the VA, for example, DOD. We can hopefully get those into the practice guidelines over time. The concern is always the generalizability. And so right now, the generalizability with depression and anxiety is still low. So we want to make sure that we continue doing the research, but it is a good signal, right, that we are able to find that EMDR does work for depression and anxiety specifically. So those are two of the things that I've been exploring and discussing. And again, you can go to EMDRnews.com and read more and get into it a little bit deeper. Also, we have our 3 conferences coming up in the next couple months. We have EMDRIA, the EMDR International Association. Their conference is mid-August, 24th, 25th, 26th, around there, that weekend. And there's a lot of awesome people coming to talk and a lot of good workshops that'll be had. So hopefully I'll see you there. I'm definitely going to be there. And then we have the ISTSS conference. That again is going to be in September. And again, it'll be in San Antonio, and I'll be there as well. And I always love talking about San Antonio. It's a nice place to visit, right? It can get really hot, so make sure that you're prepared for that. It will be September, so probably not going to be cooling down right away, but who knows. Again, you have the Alamo there, you have the River Walk. It's really nice. I really enjoyed it. I told you last time that when I was first getting into the military, that's where I did my advanced initial training, or my schooling for medical, to be a medic. And we, would steal away to downtown San Antonio from the base and kind of, enjoy myself a little bit. So it was a nice reprieve down there. So it's good memories. So we also have the EMDR HAP, or the Humanitarian Assistance Program. They're going to be doing their thing as well. And they're going to be doing that in October, and it is South Carolina. So I can confirm that South Carolina is where that's happening. Okay. All right. Yeah, so that's going to be a good one too. They're usually smaller in terms of size and what they do there, but they are no less helpful in terms of their workshops. Their workshops tend to be, very helpful. They tend to be good workshops, and they have good people coming in, and I'll be looking forward to seeing what they have there. And hopefully, as EMDR News, I'll be able to kind of post and collect some information and bring some of that to you for the people that aren't there, that haven't been able to get to the conferences or something in those lines, so that you can see what they're about and see if you're interested in setting up or planning for the following year, making sure that, hey, I want to do this. Again, they do give CEUs, and they also give EMDRIA CEUs for those that are certified under EMDRIA or looking for certification under EMDRIA. Okay, so let's see here. Yep, I think that's those pieces that I wanted to talk about today in terms of what's happening in the world. Then we can start talking about the EMDR piece, right? Trying to kind of get into a subject today on working with EMDR. So far in the last couple of weeks, I've talked about cognitive interviews, and the EMDR processing continuum. They are very important tools in terms of working with complex clients, and they really do provide that window and that door for us to get through things that are difficult. When we get to an impasse with our clients, it helps us move forward and be able to get our clients to where they need to be in terms of finding and meeting their goals. So today we can talk about clustering a little bit, okay? And I did write about this. I don't think I really got into it here yet, so we can talk about clustering a little bit. But there's just so many subjects that we can talk about with EMDR, different populations, different issues that come up. So there's never a loss for information. But sometimes I will talk about things that are not EMDR related. Like we have the VA story, where the VA had a sexual trauma group process that was successful in treating sexual trauma. And what they were identifying is the self-blame piece and working with that. Because a lot of times, and this has been shown with moral injury as well, that the guilt, the shame, the self-blame is often not as easily, when all the other screening instruments come down, the guilt, the blame, etc., those are the ones that kind of stick for a little while longer. And we need to do the work in order to help move those down. So there's a new group that was shown positive, having some positive results within the VA. Also within the VA, they looked at dreams as a different subject, but they talked about nightmares and insomnia, and same idea, right? So guilt might not be able to be completely resolved with doing our work on our EMDR traumas. Same thing. So as far as the sleep goes, insomnia also, right? The research shows might not be able to be completely resolved through working with our trauma in EMDR or with another, like prolonged exposure, another method, another treatment. So we have more work to do. And, with sleep, we have cognitive behavioral therapy for insomnia, or CBTI. That is the gold standard. And, I love doing it right now. I'm setting up a group within the context of one of the things that I work with in order to work with sleep and night. All right, sorry about that. Yes, to work with sleep and nightmares. So we're going to get into that piece there. Right? It's over 50% of people that go through PTSD treatment still have insomnia at the end of that treatment. Even when the PCL5, the screening score comes down, those other things still manage to stay up a little bit, to stay pretty high a little bit. The other piece is the nightmares, right? So 15% of those people that go through, in the study that they were looking at, that go through PTSD treatment still have their nightmares. So it's pretty significant, it's pretty interesting, and it's worth continuing to follow and continuing to think about when we are treatment planning. And we can work with nightmares using EMDR, and there's different things that we can look at. There's versions of IRT or imagery rehearsal therapy that contain some EMDR aspects. And I think I mentioned Ted Olechnik in the past, and he is a mentor of mine, and he also has some work that he's done with pairing imagery rehearsal therapy and EMDR. So if you want to look that up, that might be helpful for you. Nightmares are awesome to work with when it's happening. I tell people, I warn them, I suppose, that when I'm working with nightmares, sometimes, like with any therapy, it's like cleaning out a closet. Things get more messy before they can get clean. And what happens is usually nightmares, the type of nightmare that continues to happen, the same one over and over again, usually they are repetitive. It's the same one over and over again. So when you're working on the nightmare and all of a sudden it starts to change, it can be unnerving. It could be messy. I've had a veteran that was running towards a helicopter, and while he was running towards the helicopter, he looked to the left and his significant other was there, right? So again, pretty freaky and unnerving, right? And so that's one of those things that we look at there. And that's not to say that it's not working or it's getting worse. It's actually saying, hey, the dream has changed. The brain is looking at this in a different way. So the fact that it's weird and unnerving is good, right? And we expect that if that happens, if the nightmare changes, then as we move forward, you might actually experience further change or not remember the nightmare at all. Okay. Sometimes people still have, wake up after doing this work with a start for whatever reason, but they don't remember the nightmare. It's harder to do the work when you don't remember the nightmares. However, they can do some self-tapping, right? They can tap themselves slowly back to sleep, which has been successful for a number of clients that I've been with. And again, this is more education. Please don't consider this clinical consultation. Don't take my, don't be like, hey, Tim said it on a live, run with it. Do your own work. If you need consultation, reach out. We'll talk about individual clients in an appropriate manner. So EMDR clustering, what does that even mean? So with a quote unquote simple client, we are just talking about having that process when we do EMDR where we go from the touch-tone memory, right, that first memory within the memory network, all the way through to the past materials and the present materials and the future template stuff, right? That's all normal stuff. That's the way we kind of are taught at first. But we have complex clients, and with complex clients, things are a little bit different, right? And so we've talked about cognitive interviews, we've talked about the EMDR continuum, the processing continuum through EMD, restricted EMDR, and full EMDR. And today, the clustering is another thing that we can do, because it might be a huge map when we start to pull down our memory networks and identify how everything is connected. And with that huge map, it might be difficult to decide what you're going to actually need to work on any given time. So if we create little mini treatment plans within the context of the whole treatment plan, it can make it more digestible, more easily manageable, more easy to work with, and sometimes maybe even more effective. So, it could feel like jumping around a lot if in one moment we're talking about a past event, a touchstone maybe having to do with your mother, and it's really, really strong or something like that. And then we start working on something else, like the next memory is not about the mother, but something else, right? And then we come back to the mother later, right? Sometimes it's better if we take all the memories that have to do with a specific person, subject, event, time, etc., and try to cluster them together. And we create a mini treatment plan where we do our past, present, and future right within the context of that mini treatment plan. Right? So all the memories related to mother. So we do our touchstone, our worst, and then any other ones that have salience to them until we get some generalization. And that's the great thing about clustering, is that it allows us to have generalization within the context of these mini treatment plans, where it might have been much more difficult to get the generalization to occur within the context of a larger, more disparate, more complex web of memories. So it's helpful. It creates these little pods where we have had generalizability and we've had wins. And whenever you have a win, whenever you have a cluster that you've been able to go to past, present, and future within that cluster, you have the ability to install that as a resource to say, hey, what does that mean for you that you were able to get through that? And that resource, whatever they learned within the context of that mini treatment plan that was clustered, you can take that resource, you can take those lessons, and those become material for your cognitive interviews. They become resources that they can pull on, that they can use when things get tough in other areas that you're clustering. So it's really an important skill to have, an important thing to look at. How do we cluster? So as we start to look through our treatment plan, basically, as I said, we're looking for things that might stand out, that might be able to go together, that when we think about it, we say, okay, this could generalize, right, within the context of other like memories. And this can generalize better if we do them together, if we put them into a cluster. So we create little maps, we, create these specific little clusters, and then we decide which cluster we're going to work through first. And when we do decide that, you can go through, as we often do, which ones are more approachable, which ones will have the best effect, in terms of if I start this cluster, then most of the symptoms might diminish because it wasn't until this, like the last memory of this cluster, that all these things happened, like all these symptoms started. So we might decide that we're going to start with that cluster because it's most likely to help with our symptoms. Okay, so multiple reasons why we're going to decide what cluster to prioritize. But we are going to look at the clusters, we're going to prioritize them, and we're going to start with the ones that are most appropriate. Now, once you get the information in a cluster, you're able to clear that cluster out, there's some generalization within the cluster, you can actually make a different decision on your treatment plan based on what the information was that came from the work that you did. If you learn stuff about the client, if the client learns stuff about themselves, right, and you look at your treatment plan, your case conceptualization, and be like, hey, some of the stuff that you had to deal with in terms of confidence, bravery, courage, resiliency, self-control, so whatever quality, whatever things they had to deal with, then when you come back, you start to recognize, hey, we can use these in this other cluster, and that might be even more helpful, right? Because now we can move quicker through the different clusters as we prioritize and change our treatment plan and look at our case conceptualization. So within the EMDR, the treatment plan and the case conceptualization is always moving. So every time that we finish something, even a single memory, we get to make a decision based on what our next step is. So it's very flexible. But I tell everybody, listen, I know that you might have a specific idea of what this client needs, but take your time, get the whole map, get all the memories, right? And then we can cluster them if appropriate, because they're complex. Then we can cluster them and figure out, okay, how are we going to move forward with this client? But a habit for a lot of people is just to try and get the memories that are most likely to be connected. Again, I also challenge you to determine what makes you think that what memory is connected or not. Just because you can't figure it out and draw a line from one thing to the other doesn't mean that they're not connected. And that goes with the client too. Right? They might not draw a line from one thing to the other. But when we look at memories, we're looking at not just our thoughts, but also the other parts of it, our emotions, our physical sensations, etc. So with that context, just because we don't know how a memory is connected doesn't mean it's not. Right? All right, hold on one second. All right, I'm back. Sorry about that. So get your full map of memories, and then we can work on creating clusters around different aspects of those memories. And I mentioned before doing the touchstone within that cluster, and then the worst part, right? The worst memory within that cluster. Because what we're trying to do is trying to get to generalization, and sometimes just working on those two can help generalize. So you do your first, your worst, and then you start to look at the other memories and see if there's salience to them still, if they haven't generalized. If that's the case, then that's fine, right? And then we go and work on those. But by doing the first and the worst, we're hopefully being able to put us in the best position to get memories that generalize. Okay, so in these little clusters, and I say little, it could be long, it could be a lot of things in a cluster. Some when you say like mother, for example, and traumas that I've had associated with mother, that could be a whole life of trauma, right? So these little clusters could be pretty big. So take these clusters and you do the first, the worst, and then whatever memory pops up that still has some salience to it. And we're always doing the past, present, and future prong within these little clusters, right? So it might seem weird because you still, haven't gone through the other clusters past the prong. And that's okay. It's fine, right? This is just a way to work. We're still doing past, present, and future, and we're still going to do past, present, and future with the rest of the memories as well. We're just trying to set this up to make it digestible and manageable for both you and the client in order to make sure that we are setting ourselves up for success and for our clients to get the best experience that they can have within the context of a complex web of various memories that are connected in some way, shape, or form. And just to go back with that, right? I told you not to, like that you might not know how things are connected. The clients are the same way. So one of the things that you might find when you're doing a float back or an affect scan or just direct questioning is that when somebody has a memory come up, they're not going to tell you, right? Because they can't figure out why it's connected, so it doesn't matter. It's like, oh, I was thinking about this, but that has nothing to do with that. No, we want everything. We want anything that comes to mind, right? That when I fire up this memory network, whatever comes out, comes out. Just let me know what it is, even if you don't know or think, or even if you don't believe that has anything to do with the work that we're doing, right? Your brain brought it up. So let's try to figure out if there's a reason for that. So we'll put that on our list, our target list. When we come to that target later on, we'll determine then whether we have to process it or not. But for right now, we're going to put it down, right? We're going to make our map as complete, as integrated, as apparent, as we can. And it might take a little while to do that, sometimes over a couple of sessions. Okay, so we are going to work on clustering, and it is one of the ways to keep things moving forward along with our EMD, restricted EMDR, full EMDR processing continuum, and along with the other piece, the cognitive intermediates that we discussed. All right, so EMDR is like pretty cool, right? It's got so many things that go along with EMDR, and as we move forward and try to figure out the best thing to do with your client, just to recognize that there's a lot that goes into it, and it's about practice more than it is about anything else. As you move through and develop a tacit knowledge when working with your client, the better it'll be for you to kind of understand what your clients mean. For those that don't know, tacit knowledge is that knowledge which you cannot teach, right? It's just kind of some part of the experience that you have as an instructor or a therapist or something that you can't teach to another therapist, right? Why are you an expert and they have the same book, right? You develop certain experience and tacit knowledge along with that allows you to be the most awesome clinician that you can be. And so the same thing happens with trauma, believe it or not, is that when we are with a client, their tacit knowledge about the specific trauma might not be something that they fully understand. Just because they tell you a memory, they might not know why that memory is affecting them or what part of that memory is affecting them. They might have an idea. They might say, like, this is the worst piece, and all of these aspects of it, and they could be right. However, the other side of this is also true, that there's some tacit knowledge that they are experts in their trauma, and becoming an expert in their trauma means on some level that there's something about that trauma that they can't teach you because it's just part of the process. They're an expert at it, right? They've been through the process, yes, but they've had experience, and that experience has helped them develop tacit knowledge about what it means to be them in the context of the trauma that they are having to interface with intrusively in their daily life. So as we come to a close today, because there's not much else that I want to kind of talk about with clustering, We will continue doing these 9:30 each morning. Sometimes I'll talk more about these EMDR things. Sometimes I'll bring up some other aspects of trauma treatment and mental health and kind of move things forward that way. I hope that it's helpful. I hope that people start to have some questions. And we can look right now and see if you ever want to reach out and let me know. If you have any questions, just let me know. Okay, let me see here. I'm just taking a look to see if anybody has any particular questions right now. I disappeared at the moment as I go take a look. All right, one more place. All right, I think we are good. All right, let me go ahead and return back. All right, I am back. All right, so no questions today on cognitive interviews, well, rather on clustering, right? So we're going to move forward, and if anybody has any questions, feel free and reach out. But otherwise, I am Tim Vermillion, and this has been EMDR News, and I look forward to speaking with you tomorrow, same bat time and same bat channel.